It's a real thrill. Let me start here. All right. Is that working correctly? Can everyone see my screen?
Yes.
Oh, great, perfect. Well, thanks again. I'm thrilled to be here. It's truly a pleasure, even if it's by video instead of in person. Like everyone had shared, there are some advantages to doing this way, and it's great to have a wider reach than usual. So I'll try to make it as entertaining as possible virtually. As Dr. Suker mentioned, TTP is truly my passion. In my goals for my career to make the lives of my patients with TTP better through the work in the clinic and in our research to really try to then benefit all patients with this disease. So when I was completing my training in hematology, I was struck, I was surprised, I was disappointed to find there was really at that time little organization around the country to try to meet the needs of our patients with TTP. But in this, I saw an opportunity to try to bring together my friends and colleagues who shared my passion for this work so we could try to do better for our patients. So over about the last 5 years, I've made efforts to try to organize our research efforts with the help of my mentor and collaborator and friend, Dr. Spiro Catalan, who works at Ohio State University. So together we formed the United States Thrombotic Microangiopathy Consortium, or USTMA for short. And so today I plan to give you an overview of treatment for TTP, where I think the field is hopefully moving with new treatments, and some of the work we're doing within the USTMA to try to improve treatment of TTP. Let's see here. I think we have a poll here. So we'll dive right into to the treatment aspects that I'll cover today. But I think many of you are aware of the treatments for TTP. So we wanted to take, or I was curious to take a poll. If you could change one aspect of treatment of TTP, what would it be? Would it be to get rid of plasma exchange? Would it be to get rid of prednisone or other steroid medicines? Would it be to get rid of rituximab? Or would you be more excited to have more treatment options to keep TTP in remission? So I'll let people maybe submit their poll responses as we move along here.
Marshall, I just want to point out, I think people need to click on where it says polls.
Oh, great. Okay, yeah, it came up for me. Okay.
So if anybody sees that, click on the polls icon.
So people do some thinking on that. I'll start by saying a couple quick comments. First, that I'll talk about rituximab, which is a commonly used medicine to treat TTP, but is not specifically FDA approved for treatment of the disease. So despite this, it is considered one of the standard treatments, but I have to disclose that it's not specifically approved. And also that I've worked with Sanofi and consulting on a new medicine I'll talk about today called caplacizumab. So really, here's what I want you to get out of the talk today. First, I want to talk about where we are with current treatments. Next, move on to where we see new treatments going and how those are being tested in TTP. And then finally, help you understand how you can partner with doctors to improve treatment strategies for this disease. So let's start with a little bit about how TTP happens in the body. And I think that'll help us as we discuss these treatments. TTP is a complicated disease, and it's even hard for doctors to understand. Although I guess I suspect this is not new to many of you. I thought we'd start with this overview as a way to talk about treatments. So for most patients with TTP, this disease starts with a mistake in the immune system. our immune system has a tough job. It has to figure out who's an invader and who's not. And unfortunately, there are times when the immune system simply makes a mistake and starts attacking our own body instead of an invader like a virus or a bacteria. So this means that the most common form of TTP is an autoimmune disease, putting in the family of other autoimmune diseases like lupus or multiple sclerosis, rheumatoid arthritis, and so on. So sharing the first part of the picture here, where immune cells are making proteins called antibodies, and they have this Y shape. And the proteins have a lock and key fit for its target. And so this antibody in this disease fits ADAMTS13, a protein in our blood. And when this happens, the ADAMTS13 level in the blood goes down. And once that starts happening, we start to develop long strings of a protein called von Willebrand factor. And this starts clumping the platelets. So I like to think of this as like Velcro and tennis balls. So picture big strings of Velcro in the blood, and now as the tennis balls start floating by, they get stuck to the big sticky Velcro. And so now what we see is that these big clumps of platelets start getting stuck inside the small blood vessels of the body and cutting off the blood supply to the organs. And for reasons we don't understand right now, it appears that the brain is most susceptible to this problem. And so most people, when they get sick with TTP, will have some sort of problems with thinking. We also see that there's damage to the kidneys, less so than the brain. We can also see damage to the heart, as you've already heard about. Now, most of the time, there isn't permanent damage to the heart, but we do know the heart is clearly affected by the disease. So how does our understanding of the disease help us how to treat the disease? So the first treatment that was successfully used to treat TTP is plasma exchange. And here you can see the plasma exchange does two important things. As part of the procedure, we're removing plasma from the patient, and that means the antibodies that are causing the disease are removed. And on the other hand, we're making room for healthy donated plasma to be transfused and increase the amount of ADAMTS13 in the blood. And then that new ADAMTS13 can start to break up those platelet clots and make the disease resolve. Then we need to add other treatments. And the purpose of these treatments are to stop the immune system from making more antibodies that cause TTP. Prednisone is a steroid medicine that rapidly pushes down an immune system and has been used in TTP for many years. And in the 2000s, we had another medicine called rituximab that I mentioned before. Now, recently, we've had a new medicine invented and approved for treatment of TTP. This is a medicine called caplacizumab. And this medicine sticks to those long pieces of Velcro protein and blocks more platelets from clumping together. So this means the TTP resolves faster. It's given as an injection under the skin while you're in the hospital each day, after plasma exchange is done. And then when you're discharged home from the hospital, you give yourself the injection for about 30 days. And then sometimes, if we have to, we can extend this for another month. This was only recently approved for TTP, so it may be a new medicine both to you and to your doctors. So let me just spend another moment, because this is a new medicine, to talk about this drug called caplacizumab. And there are really two main points that we found in the two large trials on this medicine that led the FDA to approve it for TTP. Now, these were two large randomized trials, and patients and doctors didn't know whether they were getting the injection of the medicine or of a placebo. And then the medicine was added to current standard treatments. So all patients were treated with plasma exchange. And then their doctors decided whether they got prednisone, rituximab, or both, or other medicines. What we found from the trials with them was that the medicine was safe and effective. And we found that patients needed fewer plasma exchange when they got this medicine. And that meant they could go home from the hospital sooner. Now, they continued on the medicine for 30 days after the episode, which proved to protect patients from TTP coming back, which is a common and frustrating problem in the disease. So in the patients who got placebo, what we saw was that about 4 out of 10 patients came back to the hospital with TTP within a month. And that's pretty typical from what we see with this disease. But when they got this new medicine, less than 1 out of 10 patients came back to the hospital. So no drug is perfect, but this was a huge improvement in this very frustrating problem. And frankly, a very stressful problem for patients worrying about the disease coming back. So the main side effect of the medicine is that it did increase the risk of bleeding. Things like bleeding gums and nosebleeds were the most common side effect. But thankfully, most of the time, these were minor problems and the drug didn't even have to be stopped. Now, this medicine, now that it has been approved, is an expensive medicine. It's new, which is not surprising, like most new medicines. And it's a short-term treatment. This medicine is, I sometimes will describe it as plasma exchange in a shot. It just works while you're taking the medicine. So this is how I really think about treatments as 2 kind of categories of treatments for TTP. First, we use medicines and treatments to get patients into remission, and those are shown in the green box. The goal of the medicine of these treatments, plasma exchange and caplacizumab, are to rapidly stop TTP. The other types of treatments shown in the blue box are medicines that are used to keep you in remission. In these medicines, the goal is to calm down the immune system. Prednisone and rituximab are the most commonly used medicines. There are other medicines that affect the immune system. They just haven't been studied in large numbers in TTP. So we have lots of room for improvement in treatments for TTP. And here I've listed some of the things that I think are our big questions we have left to answer. The first is, can we actually replace plasma exchange with something better, meaning easier, with fewer side effects? Prednisone is toxic. I hear this all the time. It's an effective, but can be a ruthless medicine. Can it be replaced? Is rituximab actually better than prednisone all by itself? And is it better in everyone? If I relapse after rituximab, is it worth it to get the medicine again, or should I try something different? Why is it that some patients have persistent problems with memory and emotions and thinking? And can we treat or prevent this? And is there a way to predict and prevent a TTP relapse? So clearly lots of important questions to address. I think overall, when it comes to treatment of TTP, we're getting away from our traditional strategy of treating TTP just when the patient is sick and in the hospital. Most importantly here is, I think we're interested in new medicines to be tested, but also new strategies to manage and prevent the disease. And some of those are shown in the orange box here. So for new medicines to try to get patients into remission, I'll talk with you a little bit at the end about a new medicine that's being studied called recombinant ADAMTS13. And this is a highly concentrated form of the missing protein in this disease. For medicines to keep you in remission, I think 2 important new areas. One is that there are lots of new medicines being developed for immune diseases that I think could also be tested in TTP. This is really how rituximab came to this disease. It was invented to treat a blood cancer called lymphoma, and now has moved over to other immune diseases. There are also many medicines that affect the immune system that we could repurpose and we can move to TTP and test. Now, finally, I think the biggest change we'll see in TTP over the next several years is a change in our treatment strategy. We're interested in trying to understand how we can prevent and manage these long-term effects of TTP, particularly how it affects the brain, and you'll hear more from Dee about that tonight. Our biggest problem right now is that we don't actually understand why these effects on the brain linger after the TTP is over. So in order to affect it, and develop a new way to treat these, we have to understand what's happening first. And similarly, we don't have a good way of predicting when TTP will come back. But if we can better understand this, we can develop new ways of preventing episodes and avoid those hospital stays and all the stress that comes with the worrying about relapses. So here's an example of how organizing our research efforts in our USTMA group has started to turn up some interesting new findings towards our goal of making TTP treatments better. So the USTMA consortium put together a database, and this contains the demographics, treatments, and TTP episodes from over 800 patients across the US treated at our hospitals in the last, going back almost 30 years for some patients. And we wondered this important question that's been on our mind for many years now about whether rituximab being added to prednisone actually benefits our patients, or whether there might be some patients who benefited more than others. And here, there are many doctors who've been strong advocates that rituximab should be given to all patients. And I think what we're really trying to understand is, are there some patients who are more likely to benefit than others, rather than is this best treatment for everyone? So our hypothesis was that there are probably some patients who have long-term remissions from this medicine and others who do not. And if that's true, we need to be able to figure out who are those patients who benefit from rituximab and who might benefit from a different strategy. So here's what we found when we analyzed the data. We looked at all the different possible aspects of our patients and whether any of these predicted whether a long-term remission after rituximab was added. After this was done, we saw no differences, say, between men and women, between different age groups at the time of their diagnosis, between lab tests at the time they were sick. And what we found was that the only thing that predicted how well the rituximab works with was ethnicity. And you can see in this diagram, the cartoon people in red are the ones who relapsed, and those who are in blue are still in remission, and this is after 5 years from treatment of TTP. You can see those patients with African ancestry, there was no difference when we added rituximab to the treatment. At 5 years, 6 out of the 10 people had had a relapse, no matter which treatment they got. But we did see a difference among people with Northern European ancestry. Those who got prednisone had the same likelihood of having a relapse as the African American patients. You can see 6 out of 10 had had a relapse. But those who got rituximab were much less likely to relapse at 5 years. In this group, only 2 out of the 10 had had a relapse by 5 years. So it brings up some really important questions about why we saw this difference between these two groups. So is this something about the medicine? Is it something about the genetics of the two ethnic groups? And what genes could be involved in trying to understand this? And could there be genes that could tell us more so than, say, ethnicity about whether this treatment is going to benefit this specific patient? So using this information now, we can start to understand the disease and our treatments better. We can start to ask about which treatments benefit which patients. And ultimately, what we want to do is tailor our treatment to individual patients. Obviously, this is just the very beginning of this process, but an important first step. So tailored treatments are something that is commonly talked about across all aspects of medicine. As you can see, TTP is no exception. Our goal is eventually to be able to pick medicines for each individual patient rather than trying a one-size-fits-all approach that's been really our traditional strategy. So I think important questions that we need to be asked as we start to work on our treatments is, can we use new blood tests or other markers of the disease to tailor our best treatment for the patient? Can we predict when certain patients will relapse so we can prevent it? And can we understand why patients have these lingering effects of TTP so we can treat and prevent them? Importantly, we can't make life better for patients with TTP without your help. We need patients' involvement in research, both by participating in research studies, but also by helping us understand what's meaningful to patients and the problems they struggle with. So I do want to tell you about 3 important studies going on right now. First is a study of this medicine called recombinant ADAMTS13 that I mentioned before. It's a new medicine, so a clinical trial not available by your doctor. This is a highly concentrated form of the protein that's missing in TTP. And the way the study works is the medicine is given in addition to plasma exchange in the study. It's a randomized study, meaning that some patients will receive the study drug and some patients will get a placebo. And if it proves to be an effective strategy, this could be another important medication for the treatment of this disease. We also have 2 studies going on in our USTMA consortium. The first is a study of the effect of TTP on the brain over time. So we're collecting blood samples from patients and testing patients' thinking systematically over time to understand which patients are affected and why this is happening in some people. And ultimately, our goal is to develop a new treatment strategy to try to treat or prevent this big problem. Finally, we also have a study of the real-world effect of all treatments on TTP episodes, both those treatments to get patients into remission, but then also the medicines to keep people in remission. And it's called the USTMA registry. And here we're collecting patient data and samples, again, to try to understand the effectiveness and safety of medicines in the treatment of TTP. So to summarize, TTP, also commonly just called acquired or immune TTP, is a complex immune disease. Treatments really fall into these 2 categories of treatments to get into remission and a normal platelet count, and those medicines used to keep people in remission. New treatments currently being studied include the recombinant ADAMTS13 trial. This is added to plasma exchange, and new medicines to suppress the immune system. And I think really most importantly, patients have an important voice. We need to hear from you about how we can best improve treatments for TTP. You can find our USTMA consortium through our website and our Facebook page. So we're excited to engage with patients and improve TTP outcomes for everybody. Thanks so much, and I'm happy to take questions.
If anyone has any questions for Dr. Mazepa, please feel free to put your question in the chat box or use the raise your hand function.
I see there was a question about the studies. So the studies are currently available at a limited number of sites across the US, and those will be posted on our website. The study of the disease effects on the brain is currently open at my site and at here in Minnesota and Ohio State currently. And Dr. Terrell's in the process of opening it in Oklahoma. We may be expanding it over the course of the next year to other sites across the US, depending upon our funding. So hopefully we'll start to be able to get these out across the whole country. Similarly, our registry of patients is currently available at 7 sites in the US, but we plan to